Assalamu alaikum طلابنا الأعزاء. Our lecture today is about operative interventions in obstetrics. Starting from the simplest operative procedure that is done in the obstetric field, which is the episiotomy. Episiotomy means a surgical incision of the perineum that is made to increase the diameter of the vulval outlet during childbirth. There are two different techniques for the episiotomy that are widely used. The midline one, which is commonly practiced in the United States, and the mediolateral one, which is the standard in the UK, in the United Kingdom. Both of them started at the forehead, but for the midline one, it is then directed vertically down towards the Enas, while for the mediolateral one, it is directed diagonally about 60 degrees from the vertical line. And both of them, of course, are done when the head becomes crowned. So that is to say, at the time of a crowning of the head or of the presenting part. The advantages of the midline episiotomy over the mediolateral one is that it is associated with less blood loss and it is easier to repair, and after suturing the wound heals quicker and there will be less pain in the postpartum period, and the incidence of dyspareunia will be less than that for the mediolateral one. And of course, you know that the dyspareunia is pain during coital act. And this figure illustrates the site of the midline episiotomy. This is the midline one started from the forehead down towards the Enas, while the mediolateral one started from the midline, from the forehead as well, but is directed diagonally. However, the major disadvantage of the midline episiotomy is that it carries a more than 6-fold increased risk of extending to involve the anal sphincter, and in such a situation, the degree of the tear will be categorized as a 3rd or 4th degree tear when the anal mucosa is torn as well. What about the anesthesia that is required? Of course, prior to performing an episiotomy, adequate anesthesia must be administered. If the woman has already an epidural, this must be topped up. Otherwise, the perineum must be infiltrated with local anesthetic, for example, xylocaine. What are the indications of an episiotomy? The indications include the following: fetal distress, short or inelastic perineum, the occurrence of a complication which is shoulder dystocia, and this is really a horrible complication that might end with fetal distress and even fetal palsy, or giving birth for a child with mental compromisation, a birth asphyxia, or even it might lead to fetal death. Fetal, and another indication is the presence of fetal malposition, for example, in case of occipito-posterior position, or when there is with the use of an instrumental vaginal delivery, or in case of a breech vaginal delivery, or in the presence of a history of a pelvic floor surgery, for example, anterior colporrhaphy or a posterior colporrhaphy that are done for a pelvic organ prolapse. What about the complications, the possible complications of an episiotomy? It can simply imagine that the cuts that begin more laterally are likely to be more painful and more complicated to suture, and any episiotomy may bleed heavily, and hemostasis should be achieved with the pressure or arterial clamps until these lacerated vessels can be secured with the proper suturing. Of course, infection is more likely when the episiotomy is contaminated, therefore prophylactic antibiotics may be indicated. Okay, perineal injuries in general are categorized according to the degree of laceration into the following four main categories. Category 1, or the first degree perineal injury, is that when the laceration involves perineal skin only, while the second degree when it does include perineal muscle as well. Therefore, the episiotomy should be regarded as a second-degree perineal injury, while a third-degree perineal injury is when the anal sphincter is involved or included with the laceration as well. And this can be further subcategorized or subdivided into three categories, into A, B, and C. A, when less than 50% of the external sphincter is torn, while B, when more than 50% of the external sphincter thickness torn, while 3C is when the internal anal sphincter also torn. The fourth degree perineal injury include injury when there is a torn or lacerated anal sphincter in association with the torn anal epithelium. That is to say, when the laceration extends to involve the anal epithelium as well. And this figure illustrates or demonstrates the difference between the four types of perineal injuries. As you see, that the first one include laceration to the skin only, the second degree the skin and the perineal muscles, while the third degree involves the anal sphincters, whether external and or the internal one, or and the fourth degree when the anal mucosa is torn as well. Okay, how we are going to repair a perineal injury or laceration? In general, we have to ensure adequate analgesia. This is very important from the start. And in order to make the view more clear, we have to prevent the blood that is coming from the uterus from obscuring the view. This is done by placing a pad high in the vagina. And we have not to forget to remove it after completing the procedure and before discharging the woman home. And before doing the repair process, we have to check the vaginal walls and the perineum for the number and extent of cuts and lacerations. And starting the procedure by first repairing the vaginal mucosa using an absorbable suture material, for example Vicryl, on a large round body needle. And the first stitch should be started above the apex of the cut or tear. Why? Because as you know, any laceration will lead to a retraction of the vessel higher than the edge of the cut. Therefore, by placing the first stitch by about 1 centimeter above the edge of the cut will ensure adequate hemostasis. The way or the technique of suturing the vaginal mucosa should be in a continuous manner. The muscle layer should be closed using uninterrupted sutures, and then the skin, closure of the skin should follow, either using uninterrupted stitches or via a continuous subcuticular stitch that has been found to produce a more comfortable results. After that, we have to perform a gentle vaginal examination to check for any missed tears, and we have not to forget that the pad that has been placed at the top of the vagina should be removed. Then a finger should be placed in the rectum to check that no sutures have passed through into the rectal mucosa, because if this was the case, complication will follow in the form of rectovaginal fistula after a number of days. And we have to ensure via this rectal examination that the sphincter is intact. Okay, with regard to a third or fourth degree perineal injuries, that is to say, those that are associated with laceration of the anal sphincters, or those that are associated with laceration of the anal sphincter and anal mucosa as well. Of course, this needs a special attention. First of all, the tear or the repair should be done by a well-trained practitioner. Second, adequate analgesia in the form of either a regional one or general anesthesia is required, because As you know that adequate relaxation of the anal sphincter should be present in order to allow a satisfactory repair, and this cannot be achieved with the use of local infiltration. Of course, lightening must be adequate, and we have to start the repair with by suturing the rectal mucosa first, and this should be done either in an interrupted way or a continuous way. And when an interrupted stitches is placed, the node should be placed outside and not inside the lumen. After that, the torn external anal sphincter should be repaired, and this can be done in two ways. Of course, the muscle should be correctly approximated and using a long-acting sutures, either via an end-to-end repair, and this is especially allowed when the anal sphincter is partially torn, or using an overlap technique, and this is especially applied when there is a complete disruption of the external anal sphincter. And after suturing the external anal sphincter, the remainder of the perineal repair should be done as for a second-degree trauma. That is to say, the vaginal mucosa should be sutured in a continuous manner, and the perineal muscles using uninterrupted stitches, and followed by suturing the perineal skin using either an interrupted stitches or a continuous subcuticular suturing. And after completing the procedure, a lactulose or a bulk agent should be recommended for the woman for 5 up to 10 days. And of course, she should be given an oral broad-spectrum antibiotics as a prophylactic measure to prevent a subsequent infection at the site of the episiotomy. And oral analgesia is recommended as well. At 6 to 12 months, the woman should be advised to come back again for full evaluation of the degree of symptoms, for example, fecal symptoms or urinary symptoms. And in symptomatic women, especially, for example, those who are suffering from incontinence deflators or any kind of fecal symptoms, those should be offered investigations in the form of endoanal ultrasound or manometry. Now we are going to come across operative vaginal delivery. Operative vaginal delivery, as a definition, it means delivery of a baby vaginally using an instrument for assistance. And instruments, as you know, of course you heard about the instruments that can be used for delivering the baby vaginally, which is either in the form of a forceps and known as a milqat or a ventouse, يعني ماكينة. Of course, any woman will not be happy when her baby or child is delivered with vaginally using an instrument for assistance. Therefore, what are the measures that can be adapted to reduce instrumental vaginal delivery rates as a whole? These measures includes provision of caregiver in labor, this is one. Active management of the second stage of labor with ventouse, especially in nulliparous women when epidural analgesia is used, because as you know, epidural analgesia prolong the second stage of labor because the maternal urge to bear down will be lost. The third recommendation is that we have to delay pushing in nulliparous women with epidural analgesia. Other techniques that are commonly used but with no evidence of success are upright positions in labor and allowing epidural analgesia to wear off. And the fifth recommendation is that we have to ensure about the real presence of fetal distress rather than expedite delivery when fetal heart rate decelerations occur. And this can be done through fetal blood sampling, fetal scalp blood sampling, and when fetal acidosis is confirmed After that, we have to rush to expedite delivery, either using an instrument or, of course, or rushing to performing a Caesarean section when the instrument's use is contraindicated. What are the indications for assisted vaginal delivery? These can be classified into fetal indications and maternal indications. For the fetal one, this includes fetal malpositions or malpositions of the fetal head, for example, in case of occipito-transverse and occipito-posterior position, and this is more frequently seen with when regional anesthesia is used. The second fetal indication includes fetal distress in the second stage of labor that usually become evident from the occurrence of decelerations during fetal heart rate monitoring. And as I said, this should be confirmed via fetal scalp blood sampling and looking for the presence or absence of acidemia before rushing into using the instruments for assisting the delivery process. What about the maternal indications? This includes maternal distress, exhaustion, or undue prolongation of the second stage of labor. The second maternal indication is that when she has a medically significant conditions, for example, in the presence of aortic valve disease with significant outflow obstruction, or another medical condition that necessitate the use of instruments for assisting the delivery process or the second stage of labor, is when she is complaining from myasthenia gravis. Now we have to know about the contraindications for assisted vaginal delivery. These includes, for the ventouse should not be used when the gestational age is less than 35 completed weeks because of the increased risk of cephal hematoma and intracranial hemorrhage. As well, this should not be applied or should not be used when the fetus are presented with a face or in case of a breech presentation. Both, that is to say, the ventouse and the forceps, should not be used in the presence of or in the absence of a fully dilated cervix, with a possible exception for the ventouse or for the vacuum when delivering the second twin where the cervix has contracted or with a prolapsed cord at 9 cm if rapid delivery is anticipated. Regarding the ventouse, when it is compared to the forceps, it is found that it is significantly more likely to be associated with failure to achieve a vaginal delivery, more likely to be associated with the occurrence of cephal hematoma, subperiosteal bleed, and more likely to be associated with retinal hemorrhage, and more likely to be associated with maternal worries about the baby. However, it is significantly less likely to be associated with the use of maternal or regional and or general anesthesia, and less likely to be associated with significant maternal perineal and vaginal trauma, and less likely to be associated with severe perineal pain at 24 hours, while it is equally likely to be associated with the need for delivering the woman by Caesarean section and with the low 5-minute Apgar scores for their neonates. In general, what are the prerequisites for any instrumental vaginal delivery? First of all, the amniotic membranes should be ruptured, so we have to confirm that the membranes are ruptured. The second thing, and the very important thing as well, is that the cervix should be fully dilated, with a few exceptions that have been mentioned in the previous slide for the vacuum. The third important prerequisite is that the vertex representation is present with the identification of the position of the presenting part. And the fourth important thing is that for occipito-anterior and transverse positions, no part of the fetal head should be palpable abdominally, while for occipito-posterior position, it is acceptable that 1/5 of the head may be palpable That is to say, the head should be well engaged through the birth canal. In another word, the presenting part should be at least 1 plus or more below the ischial spines. We have to ensure that the woman has adequate analgesia or anesthesia, and her bladder should be emptied, and there should be no element of cephalopelvic disproportion, for example, no contracted pelvis, no macrosomic baby, and there should be no obstruction below the level of the fetal head. Examples, the presence of a pelvic kidney or an ovarian cyst, etc. And an experienced operator should be available, and an adequately informed consent should be obtained from the patient. In addition, for the forceps, we have to ensure that the blades that has been provided are matching and that they lock with ease. The analgesia required for the assisted vaginal delivery differs according to the type of the instruments that are going to be used. For example, with rotational forceps, regional analgesia is preferred, while for a rigid cup ventouse delivery, a pudendal block with perineal infiltration may be all that is needed. However, for a soft cup, analgesic requirements may be minimal. For example, perineal infiltration may suffice for this type of instrument. In which position we are going to apply instrumental deliveries? Traditionally, it is done when the patient is lying in the lithotomy position under aseptic technique. What about the instrument types? These includes 2 types: the ventouse, that is to say the vacuum extractors, and the forceps instruments. For the ventouse, they are composed of a suction cup made either of elastic or rigid material that is connected via a tubing into a vacuum source. And of course, direct extraction will then be applied to the presenting part to expedite delivery. And recently, the external suction generator now has been placed with the handheld pumps, for example, using an omni-cup. And this figure illustrates how a ventouse looks like, as you see that the suction cup is applied directly on the fetal head, on the vertex, and specifically on the flexion point, and it is connected via tubing into a vacuum pump, and the traction is applied with the direction of the birth canal. What about the technique of applying the ventouse? Of course, first of all, we have to determine the flexion point in order to apply the cup, the center of the cup on this flexion point. This is located on the sagittal suture, about 3 cm anterior to the posterior fontanelle and 6 cm posterior to the anterior fontanelle. Because if this flexion point is not determined and the cup is placed on another point, this may lead to deflection of the head, and an obstructed labor will result, and the baby will not, of course, pass through the birth canal because the presenting diameter will be increased. However, with an increasing flexion of the presenting part of the fetal head, that is to say, the fetal head, the smallest diameter will negotiate through the birth canal, and this will make the delivery easier. The operating vacuum pressure should be between 0.6 and 0.8 kg per centimeter square. And of course, after applying the cup into the fetal head at the flexion point, traction should be commenced in the plane of the least resistance along the axis of the pelvis, that is to say, along the direction of the birth canal. And the traction should be carried out gently and safely and applied in concert with the uterine contractions and maternal expulsive efforts. But no more than 2 episodes of breaking the suction is allowed, and the maximum time from application to delivery should ideally be less than 15 minutes. As you see from this figure, we are going to apply traction on the fetal head and using the ventouse, the vacuum extractor, and this is obvious that it is carried out along the pelvic axis with the direction of the birth canal, along the plane of the least resistance, that is to say downward and upward, and the traction force should be applied simultaneously with the uterine contraction and maternal voluntary expulsive efforts. It is not acceptable to use a ventouse when the position of the fetal head is unknown, because as I explained to you, that when it is applied on a point that is not a flexion point, this might lead to deflection of the fetal head and hence increasing the presenting diameter that should negotiate with the birth canal. As well, it should not be used when there is a significant degree of caput, because this indicate that there might be an element of cephalopelvic disproportion, and the labor might be an obstructed one. As well, it should not be applied when the operator is inexperienced in the use of instruments. The second type of instruments of vaginal delivery is via using forceps. The basic design of forceps is that they consist of two blades with shanks joined together at a lock, and there is a handle to provide a point of attraction. This figure shows an examples of two types of forceps. Example of a non-rotational forceps, which is the Simpson's forceps, and an example of rotational types of forceps, which is the Keelan's one. So you have to know what is the difference between the two types of these forceps. The non-rotational forceps, from its name, it cannot be used for rotating the fetal head from one position to another. That is to say, it is used when the fetal head is positioned in an occipito-anterior position, plus minus 15 degrees to the left or to the right. So this has a this has a pelvic curve and a non-sliding lock, while the rotational forceps, and as I mentioned to you, that the most famous example of these types of forceps is the Keelan one. This type of forceps is used for rotating the fetal head when it is positioned more than 15 degrees from the vertical. So it should have a minimal pelvic curve and a sliding lock for this purpose. That is to say, for the purpose of rotating the fetal head into the normal fetal position, head position. That is to say, the occipito-anterior one. What about the technique? By convention, the left blade should be introduced first and should be handled by the left hand, and using the right hand to protect the vaginal wall from direct trauma. That is to say, the left blade is inserted between the fetal head and the fingers of the right hand. Then this should be followed by inserting the right blade, that should be handled by the right operator's right hand, and inserted between the fetal head and the operator's left fingers, that should provide protection of the vaginal mucosa or vaginal wall from direct trauma. And after their insertion, they should be their articulation should be checked carefully, and they should be locked easily, and this should be done before applying a traction. Traction after their application and after the two blades are locked with ease should be done with the direction of the birth canal, that is to say, with the J-shaped curve, along the J-shaped curve of the birth canal. And the traction should be applied in concert with uterine contraction and maternal expulsive efforts. What about the possible complications of assisted vaginal deliveries in general, that is to say, those that might be associated with a ventouse or vacuum extraction, as well those that might be associated with forceps delivery? Of course, both of these instruments can be associated with significant maternal and fetal complications. The most catastrophic maternal complication that might happen is maternal death, and this is more frequently encountered when these instruments are applied before the cervix becomes fully dilated, because this will be complicated by extensive cervical tear that leads to massive maternal hemorrhage, leading to maternal death. The second possible complication is the occurrence of fetal incontinence, especially when it is accompanied or when the delivery, instrumental vaginal delivery, is associated with complicated by third or fourth degree perineal tear. Of course, postpartum hemorrhage in the absence of any laceration might be a complication of an instrumental vaginal deliveries. So, how we can reduce or minimize these complications? This can be done by adopting the following measures. First of all, by giving the mother prophylactic syntocinon infusion post-delivery, as well by prompt identification and suturing of the lacerations and tears that might happen in the genital tract, especially the cervical or vaginal perineal tears. Of course, we have to carefully identify any possible tear, especially if it is located higher up in the genital tract. What about the possible fetal complications? First is the increased incidence of cephal hematoma, which is the bleeding under the fetal skull, known as the periosteal bleed. And rarely there might be a complication, a catastrophic complication in the form of severe intracranial injuries. And these fetal complications is increased with the increasing duration of the operative delivery, as well with it is correlated with the station of the fetal head at the commencement of delivery. That is to say, the higher the station, the higher the risk of fetal complication will be. As well, it is correlated with the difficulty of the delivery and the condition of the baby at the time of commencement of the procedure. Now we are going to say something about the most important and the most famous obstetric procedure that is commonly practiced in the clinical setting, which is the Caesarean section. Caesarean section, in general, it is defined as a surgical procedure in which incisions are made through the mother's abdomen, that is to say laparotomy, and through the uterus, that is to say hysterectomy, to deliver one or more babies. The most common indications that accounts for more than 70% of cases includes the presence of more than previous one Caesarean section scar. As you know that any woman presented with the history of two or more Caesarean section scar should be delivered by a repeated Caesarean section, and vaginal delivery is never allowed in such a situation in the presence of more than one Caesarean section scar, because of the increased risk of uterine rupture during labor. As well, the second common indication of Caesarean section is dystocia, labor dystocia. The third one is fetal distress, as well fetal malpresentation, for example, in the presence of a broad presentation or a breech presentation, shoulder, etc. Other indications includes multifetal pregnancy, that is to say multiple pregnancy, or for example antepartum hemorrhage in the presence of abruptio placentae or placenta previa. As well, there might be fetal disease or maternal disease that necessitate delivery by Caesarean section. So there are many indications, but the principle is that whenever the risk to the mother and or the fetus from vaginal delivery exceeds that from operative intervention, Caesarean section should be undertaken. And this figure illustrates Caesarean section and the baby, how is the baby delivered through an abdominal incision. What about the procedure? Of course, before or starting any intervention, the patient should be consented, or the mother should be consented, and about the procedure, and this consent should be fully informed. That is to say, it should include explanation about different points. For example, the indication, the risk, possible complications, duration, etc. So fully informed consent must always be obtained, but there are special situations in which the woman cannot be consented, for example, in the presence of eclampsia in an eclamptic fit or in a comatose patients. Here, in such a situation, the doctor is expected to act in the patient's best interest. Next, after consenting the woman, of course, the bladder should be emptied. Either the woman evacuates her bladder spontaneously, immediately prior to the procedure, or via using a catheter, for example, the Foley's catheter. Then the woman should be placed in the supine position with a left lateral tilt, and of course this should the importance of a left lateral tilt is to minimize compression of the maternal inferior vena cava, and hence reducing the incidence of supine hypotension syndrome. Then, after cleansing and toweling of the abdomen, the skin and subcutaneous tissues should be incised using a number of skin incisions. The most commonly practiced one is the pfannenstiel incision. The pfannenstiel incision involves incising the skin and the subcutaneous tissue in a transverse curvilinear way that should be started 2 finger breadths above the symphysis pubis and extending from endpoints lateral to the margins of the rectus abdominis muscle. Then, after incising the skin and the subcutaneous tissue, the rectus sheath should be incised in transversely as well. Then the recti are separated. The recti, that is to say, the rectus, both rectus muscles should be separated and not incised, of course. Then the peritoneum should be incised, and this should be followed by entry into the abdominal cavity. What are the advantages of the pfannenstiel incision, which is the commonly, as I said, it is the commonly adopted type of skin incision when performing Caesarean section. The advantages of this type of skin incision is that it has an improved cosmetic results because it runs with the skin lines, and it is associated with a decreased analgesic requirements post procedure. As well, it has it carries a superior wound strength. This figure illustrates how we are going to incise the abdominal wall as well the uterine wall, and as I will explain to you in the next few slides. The second commonest example of or the second commonest type of skin incision that can be used in delivering the woman by Caesarean section is via an infra-umbilical incision. Infra-umbilical incision, this is a vertical skin incision that has a special indications because, as I said, the commonly done or the common skin incision that is used in doing or performing Caesarean section is the pfannenstiel one. But there is another type, which is the infra-umbilical incision, that has a special indications. One of them is the presence of extreme maternal obesity, or in the when there is a suspicion of the presence of other intra-abdominal pathologies that necessitate surgical intervention. For example, the presence of an ovarian cyst, mesenteric cyst, or a bowel mass, or any other intra-abdominal pathology, or where an access to the uterine fundus is required. For example, when a classical Caesarean section is indicated. Classical Caesarean section, as I will explain to you in the next few slides, is an incision that is made, a vertical incision that is made in the upper uterine segment. So, when a classical or Caesarean section is intended, an infra-umbilical skin incision is preferred over the pfannenstiel one. How it is done This should be done. This should be started by incising the abdominal wall in the midline, starting from below the umbilicus downward to the symphysis pubis. And this has the advantage of extended, that it can be extended caudally towards the sternum, so it can be enlarged in special situations. What are the advantages in general of a vertical skin incisions? That is to say, the infra-umbilical one is that it provides a greater ease of access to the pelvic and intra-abdominal organs, as well it can be enlarged more easily towards the sternum. But this type of skin incision has a disadvantage, that it carries a higher incidence of wound dehiscence later on. This figure illustrates the types of skin incisions that are used when performing Caesarean section. As I said, the commonest and the widely practiced one is the pfannenstiel incision, followed by the midline vertical that has a few indications, and there are a number of other types, the most famous of which is the Maillard, and the fourth type of a skin incision that you may hear in your clinical practice is the jewel Cohen. What about the uterine incisions? Of course, the commonly adapted uterine incision that is practiced in over 95% of Caesarean deliveries is the lower uterine segment one. That is to say, the C-shaped incision that is done in the lower uterine segment. This type of skin incision carries the advantages, a number of advantages. First of all, the ease of repair. Second, there is a reduced blood loss intra-op, and it has a low incidence of dehiscence or rupture in subsequent pregnancies. While the second type of uterine incision, that is known as the classical one, as I said, it is a vertical incision that is done through the upper uterine segment. This has a relatively few indications. These includes when there is a uterine fibroid, or when there is a fibroid in the lower uterine segment, or when the lower uterine segment is covered with dense adhesions, making entry into the uterine cavity difficult. Because both of these situations, that is to say, the presence of a fibroid in the lower uterine segment as well as when it is covered with dense adhesions, of course will make any incision in the lower uterine segment much more difficult to be done. The third indication of a classical Caesarean section is when there is a placenta previa, especially when it is present, when it is covering the lower or when it is anteriorly located, or when it is of grade 3 or 4, that is to say major placenta previa, or in the presence of a transverse lial theta, especially when the back is inferior. As well, there is another fetal indication is when there is a conjoined twins, and when sixth possible indication is that when Caesarean section is performed in the presence of carcinoma of the cervix. This figure illustrates the sites of two types of uterine incisions. As you see from figure A, the pfannenstiel one is a C-shaped incision that is made through the lower uterine segment, while the classical one is a vertical incision that is made in the upper uterine segment. Of course, the vertical incision carries more risk of dehiscence in subsequent pregnancies. Now, after incising the uterus and delivering the fetus, an oxytocin at a dose of 5 international units syntocinon should be given intravenously. That this will aid uterine contraction and the placental separation. And after its separation, it should be delivered immediately by controlled cord traction. Then, after delivering the placenta, the uterus should be closed either in a single layer or in a double layer, using either continuous or interrupted sutures. After closing the uterus, the abdominal wall should be closed in an anatomical planes. That is to say, the peritoneum should be closed, the visceral, and then the parietal one, and followed by approximation of the rectus abdominis muscles, and then closing the rectus sheath using a nylon suture, non-absorbable suture material, or a long absorbable suture material, and then the subcutaneous tissue should be approximated, and the skin follow. And our last step is closing the skin commonly by using the subcuticular suturing for better cosmetic results. Now we will mention a few important points about the possible complications of Caesarean section. Of course, this might include damage to the nearby structures, that is to say, visceral damage, for example, bowel damage, bladder injury, ureteric damage, etc. Or the operation might be complicated by severe bleeding, hemorrhage that necessitates removing the uterus at the same time, that is to say, performing Caesarean hysterectomy, and this is especially indicated when in the presence of in the presence of a previous Caesarean section scar with the placenta implanted over the site of the previous scar, increasing the risk of placenta accreta. The third possible complication is the presence or the occurrence of hemorrhage that might happen because of laceration to the adjacent or nearby uterine vessels, or in the absence of damage to the uterine vessel. It might happen incidentally because of uterine atony, or in the presence of a placenta previa, because, as you know, the lower uterine segment cannot contract and retract efficiently as the upper uterine segments. That is to say, in the presence of a placenta previa, there will be no massive hemorrhage from the placental bed compared to that from a normally sited placenta. And thank you for your listening.